Well, good afternoon, all. We're going to continue on with our spinal cord injury lecture series. Before I begin, can somebody give me a thumbs up? Just let me know that you're hearing me okay. And thank you, and seeing the slides. So good. So we're going to talk about fat gone wild, neurogenic obesity after spinal cord injury. And I think you'll understand the title more as we go ahead and get started through the presentation. My hope is to briefly review, only briefly, spinal cord injury and its comorbidities, but to describe the causal relationship between neurogenic obesity that accompanies spinal cord injury and the metabolic syndrome. Then we'll talk through the physiological changes after spinal cord injury that offer us unique opportunities to look at exercise in nutrition. In this special population probably required these interventions in a much more rigorous way than in any other population that we'll come across. And then we'll talk through a little bit about additional research opportunities in spinal cord injury across the spectrum. So it's no accident that SCI is smack dab in the middle of the word interdisciplinary as we talk about the interdisciplinary care required for folks with spinal cord injury. Our mission is to help get an individual through the acute sustaining process, teach them and their family, provide psychosocial and vocational rehabilitation, and then to allow them to participate in research and learn more about spinal cord injury as we go through. All of these specialty services will be involved with spinal cord injury care. And why is that? Well, as you all know, the central nervous system is comprised of brain and cord. When you have an injury to the cord, you're going to knock out everything below the level of that injury. And so we list out in the somatic nervous system the level of injury, the completeness of injury, but we also have to take into account the autonomic nervous system, particularly the sympathetic nervous system that arises from the thoracolumbar cord. So remember that parasympathetic and the sympathetic nervous system make up the autonomic nervous system that has very, very broad applications throughout the body. And particularly as we look at the sympathetic nervous system, we recognize that the cardiac plexus rises from T2 through T4, the celiac ganglion from T5 through T11. And so the sympathetic nervous system basically conveys our fight or flight ergotropic responses. So in the event of a crisis, the sympathetic nervous system takes over and mobilizes as quickly as possible substrates. It accelerates the cardiopulmonary system so that we can get oxygen and nutrients to the muscles as quickly as possible to either fight or flee, as the case is. And you remember, after a crisis situation, the parasympathetic nervous system kind of takes over to replenish all of the things that were utilized during the crisis of the sympathetic nervous system. And so the parasympathetic nervous system provides energy conservation and trophotropic influences, basically to prepare the body for the next major crisis situation. Now, at any given time, you know that the sympathetic nervous system and the parasympathetic nervous system never turn off. They are always on, but to various degrees. After spinal cord injury, we worry about autonomic dysreflexia, which is a massive sympathetic outflow in response to a noxious stimuli below the level of the injury. And particularly for those individuals with injuries T6 and above, they are at risk for this hypertensive crisis associated with splanchnic vasoconstriction and the complications associated with that, including stroke, seizures, organ failure, and death, all of which are suboptimal. Yes. Why is T6 such an important level? Because generally speaking, we have to remember the greater splanchnic nerve, and that provides the sympathetic nervous system activity to the entire splanchnic vascular bed, the largest vascular bed in the body. So the splanchnic, greater splanchnic nerve typically comes off at T7 and T8. In some individuals who didn't read the anatomical textbooks, they might come off at T8 and T9. And so you may have, fairly rarely, some individuals with T7 or T8 spinal cord injury who still get autonomic dysreflexia. The other thing to keep in mind is the nerve to the adrenal medulla also comes off at the T7 and T8 level. And remember that the adrenal medulla is essentially a post-ganglionic sympathetic ganglion. And so it's going to be releasing catecholamines, epinephrine and norepinephrine as we go through there. So any noxious stimuli, but typically we think of the number one cause being bladder. The bladder distends and afferent signals ascend the cord, but are blocked at the level of the spinal cord injury, and you get a reflex sympathetic outflow with splanchnic vasoconstriction and subsequently hypertension. Increased pressure is sensed by baroreceptors that send information to the medulla. Medulla sends information back to the heart to cause a relative bradycardia, but below the level of the injury, the person remains vasoconstricted. Above the level of the injury, there's flushing, sweating, this pounding headache, all of which we describe as autonomic dysreflexia. So now I want to step into what are we really talking about today. I've talked through the levels of spinal cord injury and the autonomic nervous system. Let me tell you about a patient that I had the opportunity to manage a few years ago. It was a 24-year-old Army Ranger, and he unfortunately had a gunshot wound to the neck while serving our country. He had a C4 burst fracture requiring laminectomy and fusion, and subsequently developed C4 Asia Impairment Scale A tetraplegia. He also had, incidentally, mandibular fracture requiring surgical intervention. He was on mechanical ventilation when he came to us with a tracheostomy and a PEG, and unfortunately a stage 3 pressure injury. So this gentleman went from being one of the most elite physical specimens on the planet to having the spinal cord injury and all of these related comorbidities because of that gunshot wound. And while we didn't see it originally or initially, very soon he was to develop obesity and metabolic syndrome. So what are the dangers associated with obesity? I don't have time to go into these in great detail at the moment. I'm going to be spending most of this lecture talking about the first 5 or 6 of these, but recognize that obesity now is, aside from COVID, is one of the major killers in the United States. And folks are always asking, is it possible to be obese but still healthy and working out? And we have to recognize that even those folks who are initially healthy, as they spend time in the United States, they're going to change. And as they change, phenotypically, they become at high risk for those other dangers that we were talking about. So yesterday, the 27th edition of Topics in Spinal Cord Injury Rehabilitation came out, the spring edition, specifically on neurogenic obesity. And so we know that neurogenic obesity reflects excess body fat because of motor paralysis, obligatory sarcopenia, sympathetic blunting, anabolic insufficiency, and a blunted satiety, in which we have energy intake significantly exceeding energy expenditure. We also know that obesity mediates the metabolic syndrome. That is, it causes insulin resistance, hypertension, dyslipidemia, thromboembolism, and coronary artery disease. And Dr. Farkas and Tiozzo helped me put together the first of the manuscript in the edition about the pathophysiology of neurogenic obesity. So metabolic syndrome is defined in different ways depending upon who you're listening to. So the National Cholesterol Education Project had the Adult Treatment Panel 3 identification of abdominal obesity plus triglycerides, HDL cholesterol abnormalities, blood pressure, or fasting glucose. So any 2 of those, in addition to abdominal obesity, measured by waist circumference. The World Health Organization defined obesity somewhat similarly, but they ranked insulin resistance as the major culprit associated with this, plus any 2 of the following. So hypertension, dyslipidemia, obesity, or albumin excretion indicating kidney dysfunction. The International Diabetes Federation in 2005 put all of the definitions together, and they put forward this one, now reporting central obesity as waist circumference. If you're European, a man or a woman, you are only allowed 37 inches for men, 31.5 inches waist circumference for women. Of course, if you're a US citizen, you get a couple extra inches there. But the physiology doesn't change. I just want to say that. Plus any two of the following. So again, a dyslipidemia, either looking at triglycerides or HDL cholesterol, elevated blood pressure or treatment for elevated blood pressure, and a fasting blood glucose greater than 100 milligrams %. So we reported out, I guess just a couple of years ago, in 473 veterans with spinal cord injury, using the surrogate of BMI greater than 22 kilograms per meter squared. And I know what you're thinking, 22 kilograms per meter. I'm over 22 kilograms per, what? But this is for folks with spinal cord injury, and I'm going to explain why as we talk about body composition in a moment. But basically, 3/4 of this population of veterans were determined to be obese by BMI. More than 2/3 had dyslipidemia with HDL cholesterol less than 40 milligrams %. About 50% had impaired glucose, that is fasting blood glucose greater than 100 milligrams %, or were under treatment for diabetes. And this was crazy, at least for me, 55% of them had hypertension. So in fact, 57.5% had metabolic syndrome using BMI as a surrogate. Now, I don't like to use BMI as a surrogate for obesity in spinal cord injury because it doesn't take into account adipose tissue. So we reported out in this special edition of Topics that came out yesterday on 72 individuals with motor complete spinal cord injury. 72% had paraplegia with a mean age of 44. When you look at 4-compartment modeling, and I'll discuss this a little bit later, to determine percent body fat. And by the way, obesity is, for men, considered more than 22% body fat, for women more than 35% body fat. When we used this metric to look at obesity, we found that in this population, 97% were in fact obese. Only 82% of them would have been considered obese if you looked at BMI. 83% had dyslipidemia. That means their HDL cholesterol was less than 40 milligrams % for men, less than 50 milligrams % for women. 32% had what we would call impaired glucose tolerance with fasting blood sugars greater than 100 milligrams % or under treatment for it. 43% of this population had hypertension by the most current definitions, and in fact, almost 60%. When we look at percent body fat to determine obesity, 60% of these folks, in fact, had metabolic syndrome. So how do you treat the metabolic syndrome? Well, diet and exercise, neurobehavioral activities to reduce obesity, and then all of these other pharmacological interventions. Now, I got to take at least the top 3 of these off the table because it's just not appropriate to use these for folks with spinal cord injury with autonomic dysfunction and or neurogenic bowel. So please don't provide orlistat to your patients with neurogenic bowel. We'll talk about in one of the upcoming lectures. But basically, you're going to leave them incontinent and socially paralyzed if you're using orlistat. Certainly, we want to manage their blood pressures. Are they really elevated in people with spinal cord injury? We'll come back to that. Use lipid-lowering agents appropriately, and then treat their diabetes. Now, I do have to put a caveat in here. These are insulin sensitizing agents, okay? And as such, what it does is it, remember, insulin facilitates the entry of glucose into the cells. And so these work, but as they get the blood glucose out of the blood and into the cells, it's converted to fat. So by using these agents, most of the time we see an increase in body fat, at least initially, in our folks with spinal cord injury, unless we incorporate diet and exercise, moving along with that. So this is a great diagram to kind of express what's going on, and it's included in that first manuscript in the topics on pathophysiology of neurogenic obesity. Recognize that essentially environmental genetic factors in persons with spinal cord are going to increase peripheral adipose tissue, AT. As we increase adipose tissue, it's going to have influences on vascular inflammation, on lipids, on insulin resistance, and on hypertension. And so basically, we also know adipocytes impair fibrinolysis because they secrete sticky substances, thrombin activatable fibrinolysis inhibitor, TAFI, and plasminogen activator inhibitor, PI. TAFI and PI are sticky, and they in fact cause thromboemboli to occur. These are secreted from adipocytes. We also know that they are pro-inflammatory, particularly secreting interleukin-6 and tumor necrosis factor alpha, which are converted in the liver to C-reactive protein. C-reactive protein increases nuclear factor kappa B, decreases nitric oxide so that you end up with a relative vasoconstriction, high blood pressure, increase leukocyte adhesion, and increase endothelial cell apoptosis, as Dr. Farkas had pointed out in his 2018 manuscript. And we know that folks with spinal cord injury do have at least elevated C-reactive protein levels. We also know that obesity seems to put folks at higher risk for immunosuppression. And there have been some recent manuscripts. There was one more that just came out a few months ago I should include on this slide. But the bottom line is the more adipose tissue you have, the higher risk you are for developing all types of infections. And part of that is related to the inflammation associated with obesity. So that, just a little bit of fat that, all of us typically when we're young and healthy and active, we don't have too much, but as we accumulate more fat over the years, and particularly our folks with spinal cord injury accumulate adipose tissue, you see a significant change in their pro-inflammatory profile, which also affects their immune system. We know that adipocytes cause hypertension by at least 4 and actually probably 5 different mechanisms, partly through their secretion of angiotensinogen, which gets converted to angiotensin, potent vasoconstrictor. We also know that the interleukin-6 C-reactive protein reduces nitric oxide so that you have diminished vasodilation. As you also accumulate free fatty acids, it puts you at higher risk for atherosclerosis. The compression with all of this visceral fat on the abdominal organs and particularly the kidneys, we see an increase in plasma volume and an increase in, again, those things leading to hypertension. And we first reported this in 2007, and folks were fairly shocked. As one of the authors on this particular manuscript, I was shocked too. I was really surprised that we saw 23% of our population had blood pressures greater than 140/90, and it was truly not autonomic dysreflexia. But 40% had a relatively high blood pressure for persons with spinal cord injury. And this was in a sample of approximately 8,000 veterans from across the, at the time, 23 centers in the nation. We know that visceral fat also causes dyslipidemia. Remember that as you increase the non-esterified fatty acids, you increase the LDL cholesterol and decrease the good HDL cholesterol. And so as these non-esterified fatty acids accumulate, basically you put yourself in a very lipemic environment, and the liver continues to be overwhelmed. as you have visceral involvement. And a number of studies have reported this out. Bauman of note in 2007 showed that 2/3 of folks with spinal cord injury had HDL cholesterol less than 40 milligrams percent, and 44% had HDL cholesterol less than 35 milligrams percent. So the recent publications that we put out were very much in line with some of the previous literature had showed. And then we also know that adipocytes cause insulin resistance. So these are all the components of the metabolic syndrome. They secrete the interleukin-6 tumor necrosis factor alpha that is associated with insulin resistance. As they accumulate free fatty acid within the cells, the liver and skeletal muscle cells, they actually impede the PI3 kinase cascade and limit glucose getting into the cell. Remember what that looks like. So you have the accumulation of glucose in the bloodstream outside of the cell, and that precipitates the release of insulin from the pancreas, stimulates the PI3 kinase cascade, which activates the GLUT4 receptors, and they translocate to the membrane, allowing the passage of the sugar into the cell. Now, able-bodied individuals who have good energy expenditure, that's not a problem. But for those who are not expending a significant amount of energy, like those with spinal cord injury, the glucose is subsequently converted to fat and stored as adipocytes. So there are, in fact, 8 different mechanisms recently reported that demonstrate how obesity, and adipose tissue in particular, impairs insulin signaling cascade. And I don't have time to go into all of this at the moment, other than to say glucose intolerance is present in spinal cord injury. And we've known that since the mid-1990s when Bill Bauman out of the Bronx VA and his group reported several different manuscripts showing impaired glucose tolerance in persons with spinal cord injury. And again, Sherry Lavella reported out in 2006, I was part of the group, that approximately 20% of veterans with spinal cord injury reported diabetes, but they really didn't know what to do about it. So the American Diabetes Associated guidelines tell us that we should be using glucose-lowering medications for this type 2 diabetes, basically starting with metformin. And again, I don't have time to go into this in detail at the moment, but we can talk through at a later time. We also had a publication in this special topics edition discussing insulin resistance related to neurogenic obesity after spinal cord injury. And that was first authored by Dr. Gordon. So part of this is related to glucose tolerance. If you look at area under the curve in a 2-hour glucose tolerance test, the pink in this case represents able-bodied individuals of approximately the same age as persons with spinal cord injury that were tested. The bright green represents those with tetraplegia, and you see that they, after ingesting the beverage, within 30 minutes, they had a very rapid increase in blood sugar, but it remained elevated throughout the course of not just a 2-hour, but a 3-hour glucose tolerance test. Those with paraplegia fared a little bit better, but still had elevated area under the curve compared to able-bodied individuals. And in fact, as we looked at this a little closer, and we compared the glucose area under the curve on the y-axis with percent body fat on the x-axis, we found a very strong relationship for those folks with C7 to L2 spinal cord injury. When we looked at just paraplegia, and we weren't considering so much of the autonomic dysfunction, that line became very, very tight. So there is a very tight relationship between glucose, and I should say insulin resistance, and percent body fat in persons with spinal cord injury. Dr. Nash reported out, and I was on the panel that put this together, cardiometabolic risk after spinal cord injury. This was reported in the Journal of Spinal Cord Injury Medicine in 2019. And essentially what we said, it boils down to cardiometabolic risk is high in persons with spinal cord injury because of obesity, prediabetes, and diabetes, hypertension, and dyslipidemia. And the recommendations were that we look at nutrition and physical activity primarily to try to change the obesity, that is the adiposity load, and then use pharmacotherapy to manage the diabetes, hypertension, and dyslipidemia. So why do folks with spinal cord injury have such high body fat? If you take a look at the acute energy needs, now remember, Harris-Benedict equation is still being used in our hospitals today to predict the energy expenditure or energy requirements for persons in the hospital. For males, the equation looks like this, and it incorporates their weight, their height, and their age. For females, similarly, incorporates weight, height, and age. And it gives you a number, and then they say you should correct that number by 20%, increasing it by 20%, even for inactive individuals. And so if you think back to the veteran that I told you about earlier, the Army Ranger, 24 years old, 160 pounds when he came to us, 6'1", now with the C4 complete spinal cord injury. By the Harris-Benedict equation, his predicted basal metabolic rate would have been 1,827. The correction factor just for sedentary activity would have put him up to 2,200 calories per day. But because he was also a trauma patient, they actually recommended that we increase according to the trauma guidelines by 60%. And so the dietitian from the acute service recommended that we be feeding him 2,900 calories a day. And we were a little worried about that. So we actually did indirect calorimetry to determine his resting energy expenditure. When we did that, we found that his actual energy requirements were only 1,280 calories per day. And this would represent an excess daily of 1,600 calories of positive energy balance. That would have resulted in, over the course of a week, 11,500 calories, which is 3.2 pounds of fat. And over a month, 49,000 excess calories, which would result in the accumulation of 14 pounds of fat. Now, you wouldn't have recognized that because he's going to also be losing, because of his paralysis, muscle mass and bone mass, which are metabolically active tissue. So just to follow up on this, Rodriguez out of New Mexico in 1991 reported that this is not just a matter of trauma. If you compared non-spinal cord injured individuals with those with spinal cord injury and you fed them excess calories and plenty of protein, you would achieve nitrogen balance in able-bodied individuals by week 3. But you continue to lose nitrogen, that is muscle mass, in spinal cord injury until at least week 8. They continue to lose muscle mass. Why? Because they're not activating the paralyzed muscle. They reported out again in 1997, a larger group, and they said it is inappropriate to use predicted energy expenditure. But if you're going to use it, and particularly the Harris-Benedict equation, please do not use the multipliers, either for sedentary activity or major trauma. Because these individuals have an obligatory sarcopenia, that is muscle atrophy due to paralysis, and their resting energy expenditure diminishes with nitrogen loss. Now, your resting energy expenditure is comprised of 30% of your total daily energy expenditure goes to your liver, 7% to your kidneys, 10% to your heart, 20% to your brain, except for you all. I know you're more like 25%, maybe 30% of your energy is going to your brain. I get that. The most variable, however, of all of these energy requiring organs is skeletal muscle. And so the more muscle you have and the more you activate that muscle, the more calories you burn. And there is, in fact, a very tight, direct relationship between resting energy expenditure and fat-free mass. Fat-free mass is comprised of muscles, bones, and organs, okay? So you can look at persons with spinal cord injury, and this equation will hold true. You can look at men, you can look at women, you can look at the pediatric population. There is a tight relationship between fat-free mass and your resting energy expenditure. Now, total daily expenditure is comprised of your resting metabolic rate plus the thermic effect of activity. So when you're doing exercise or just out moving around, you're going to burn approximately 15 to 30% of your total daily energy expenditure would be based on that thermic effect of activity. And 7 to 10% of your total daily expenditure goes to digestion of what you eat. So nonetheless, approximately 2/3 to 3/4 of your metabolic rate is based on what the body needs to sustain itself at rest. If we look at total daily energy expenditure for an able-bodied individual, take somebody like myself who has an energy expenditure of about 2,800 calories per day. If I was to sustain a spinal cord injury, and let's be generous and say it's paraplegia, my total daily energy expenditure would drop from 2,800 to about 2,240 calories per day. Part of that, my resting metabolism drops, but so does the physical activity. I have smaller muscle mass to work with and less activity. Even the thermic effect of food is diminished after a spinal cord injury. But if we weren't generous, if in fact I was to have a high spinal cord injury in the cervical region, my total daily energy expenditure would drop by more than half. Basal metabolic rate, the thermic effect of physical activity, and even the thermic effect of food would drop, so that my total daily requirements would only be 1,200 calories a day, meaning that if I ate more than that, and let's just say, I had a couple of potato chips, and that put me over by 200 calories per day, what my energy expenditure was. Over the course of a year, that would be 73,000 calories, which would be 21 pounds of adipose tissue now on my body. And yet I've lost muscle and bone mass, and so my body weight might actually be less than it was before my spinal cord injury. So somehow we have to reestablish this energy balance, potentially increasing our energy expenditure or decreasing our energy intake. Now, I've mentioned before, I've got a little bit of a bias against body mass index. And part of the reason for that is it is only a one compartment assessment of a body weight. It doesn't discriminate fat-free mass from fat mass. It only tells you body weight. And so the bottom line is we know that BMI underestimates obesity and spinal cord injury significantly. How significantly? By 30% or more, depending upon the level of a spinal cord injury. We reported out that if you just look at body mass index, what if you're both European and US citizen? I just saw this for the first time, George, sorry. I guess you could split the difference, but physiologically, the body doesn't care. Sorry, buddy. The body mass index, what I want you to know is that for a body mass index for persons with spinal cord injury, a BMI of 25 represents approximately 35% body fat. 35, a third of your body weight is fat mass. So what is your optimal body weight? We could look at body mass index. We could look at height weight tables. Body composition assessment has been around for 60, 70 years, basically. And what we do is we strip the body down into its respective components of muscle mass, fat mass, and organs, as well as skeletal mass. So this was all based on cadaver analysis. I'm not going to bore you with the details on this, but all of body composition assessment was initially based on just 3 male cadavers. Sorry, ladies. Ages 35, 25, and 46. And we determined the density of these different tissues within the body. And then we can use body composition techniques since that time to get an idea of the body composition. How much of the body is water, how much is fat, how much is bone, and how much is muscle and organs. So Four-compartment modeling is the gold standard to determine percent body fat, and employs underwater weighing, DEXA scans to determine bone mineral content, and deuterium dilution or bioelectric impedance analysis to determine total body water, so that we can break the body down into its components of residual dry mass, bone, total body water, and fat. And so we recently reported, yesterday, out on this. For 72 individuals, 59 men, 13 women, ages 44, with a height of 174 centimeters and weight of 83 kilograms, their body mass index was 27.3. Their percent body fat was 42%. 42%. This was the mean, by the way. So there were a number of folks in our sample who had more than 50% of their body weight as fat mass. And again, we just reported this out yesterday. There are a number of comparisons that we could look at. We actually developed an equation that could be used in the clinic, and we'll be sharing that with you all in the near future. So a BMI of 27 for persons with spinal cord injury is translating to 42% body fat in persons with spinal cord injury. So we know that our folks have about twice the load, the adipose tissue load, as able-bodied individuals. I'm not sure that there are distribution differences in that fat. We know that their fat-free mass is diminished, bone mineral content is diminished, total body water is diminished. We do know that they have elevated cytokines, particularly high-sensitivity C-reactive protein is about 4 times normal in most populations with spinal cord injury, and they're at higher risk for thromboemboli. So how do we establish energy balance? I'm glad you asked. We could look at energy balance as reported yesterday by Dr. Farkas, Dr. Snide, and myself, where we talk about determining energy balance and looking at different components to do that. Part of this is going to be based on energy expenditure, and so we're going to look at an exercise prescription that will allow us to increase total daily energy expenditure and perhaps increase the amount of food that we can eat. Now recognize when you go to prescribe exercise for a person with spinal cord injury, you have to include these comorbidities. These are all things that you need to take into consideration as you prescribe exercise. So it's not like just prescribing exercise for me or one of your colleagues. There are a lot of things that you have to take into consideration. And I'm not going to beat it to death. We have a separate lecture just on exercise prescription for spinal cord injury. But recognize that folks are going to be at high risk and should probably be tested with a graded exercise test to determine their functional abilities. If they're only going to be using their upper extremities, they are at high risk for circulatory hypokinesis, that is passing out as they exercise. And recognize that the upper extremities burn significantly fewer calories, even at the same heart rate and the same perceived exertion level than using lower extremity work. And so our folks are, if they're relegated to just upper extremity exercise, they're not going to be able to burn as many calories. If you go and look, Barb Ainsworth put out the Compendium for Physical Activity. You can get on it on the website. There are books about this, but basically consider any activity that you would like to participate in, and she can tell you how many calories you're going to burn for that particular activity. We didn't have this for persons with spinal cord injury until we put together a study that was reported out in 2010. And what we found is that a metabolic equivalent, doesn't seem like much, but a metabolic equivalent for an able-bodied individual is 3.5 milliliters of oxygen per kg per minute exercised. That's not exercise, that is just at rest. A metabolic equivalent for a person with spinal cord injury would be determined to be 2.7 milliliters of oxygen per kg per minute. And the higher the level of the spinal cord injury, the lower the work output that they were able to put together. So again, we'll go into this in much more detail. in an upcoming lecture. But have we been looking at exercise for spinal cord injury appropriately over the years? And those of you who've seen the movie I, Robot recognize that Detective Del Spooner has basically an artificial limb that was developed by Dr. Alfred Lanning, and that technology was used to create robots, et cetera, et cetera. The bottom line was the doctor was killed, murdered, and there was yet this little hologram projecting device that would answer limited questions. And so Detective Spooner would ask, certain questions, but he kept getting this response: "I'm sorry, my responses are limited. You must ask the right questions." And I say that we haven't been asking the right questions when we talk about prescribing exercise for spinal cord injury. And the question is it possible to achieve negative energy balance after spinal cord injury? Recognize that you have all of these comorbidities. How should you prescribe exercise? Well, David McMillan and crew reported out, yesterday, how to provide an exercise prescription specific for fat loss after spinal cord injury. And again, we'll go into that in more detail in an upcoming lecture. We had done a study a while back. It was a randomized, baseline controlled, prospective design study looking at 4 months of aerobic exercise provided to folks with L2 to T4 motor complete spinal cord injury. And our primary outcome measures were percent body fat, insulin sensitivity and glucose effectiveness, and VO2 peak. Also looking at lipid profiles, bone mineral density, and some psychosocial outcomes. We reported out on this, yesterday. And in Farkas's report, basically we show there is a reduction in percent body fat, systolic blood pressure, diastolic blood pressure, and an increase in fat mass, an increase in HDL cholesterol, and increased energy expenditure per session for both groups, arm crank as well as functional electrical stimulation, leg cycle ergometry, but body weight actually increased. And that's because we allowed these folks, we asked them to don't eat more just because you're exercising. But I think somehow they felt like they were entitled now that they're exercising to eat more. And so even though their percent body fat decreased, their total body fat load increased. It's just that their fat-free mass increased to a greater extent than that. So again, how do we reestablish the energy balance? First, we do need to consider the regulation of food intake. And we've not really done this well over the years. And in fact, our folks with spinal cord injury appear to have a decreased ability to become satiated. They don't know when they're full. And so we think that we should be providing fewer calories. If you go all the way back to 1985, Cox put forward these formulas, but they haven't been validated and they haven't taken into account other aspects of what we need to do, including looking at energy expenditure and measuring that, as Farkas Snige and I reported out in topics yesterday. Basically looking at indirect calorimetry to determine energy expenditure at rest, and then converting that to basically total daily energy expenditure that could be used. So there is an equation that Dr. Farkas has reported out where we modify and we look at the ratio of the 2.7 divided by the 3.5 milliliters per kg per minute. And the bottom line is the total daily energy expenditure for spinal cord injury is a reflection of their basal metabolic rate times 1.15, and that works out fairly consistently in this group. We've reported out total daily energy expenditure and what that should look like for persons with spinal cord injury. Dr. Farkas has actually done a nutritional meta-analysis. And so those of you who are wanting to do a meta-analysis, this is a great example of what needs to go there. What he showed, though, is that when you look at all of these studies together, for persons with spinal cord injury, people they had a significant excess. 160 kcals per day, 58,000 kcals per year. That would be the accumulation of 16 and a half pounds of adipose tissue gained per year. And so we do recommend that folks try to spare the high calorie ratio foods, flour, sugar, oil, and alcohol, and instead stick to vegetables, beans, legumes, mushrooms, fresh fruit. Consider a Mediterranean diet, except that you realize that you still have to keep the total calories below their total daily energy expenditure, or they're going to be in a positive energy balance. And again, we reported out diet and dietetics, particularly for persons with spinal cord injury, in order to maintain a negative energy balance. So we do know that there are a number of physical barriers remaining to folks who are trying to participate in exercise, not the least of which is parking, equipment access, restroom access. And so we are looking at exercise intervention. This is the science project that most of you know about: spinal cord injury, exercise, nutrition, conceptual engagement. This is we're recruiting starting, actually, I hope next week, although we have a meeting this week to talk about it. We'll be recruiting subjects with injuries above T4, motor complete, that is Age Impairment Scale A and B, and we're going to provide them a 200 calorie a day deficit, either through diet alone over 4 months, or through diet and exercise using functional electrical stimulation, leg cycloergometry. And we're going to be looking at percent body fat, fat mass, fat-free mass. We'll use an intravenous glucose tolerance test to determine glucose effectiveness and insulin sensitivity. We'll be looking at lipid profiles and pro-inflammatory cytokines. So I have rapidly got through this lecture that includes an awful lot of information about obesity after spinal cord injury. We recognize that adipose tissue is in fact the central mediator of the metabolic tissue, including central obesity, dyslipidemia, hypertension, and insulin resistance. And we really need to be focusing our treatment options on behavior modification. Certainly pharmacologically, we need to manage blood pressure, lipids, and insulin resistance as we go through there. So I've got a few minutes for questions. I covered an awful lot of material very, very quickly. So feel free to bring up any thoughts, questions, concerns. While this is specific to spinal cord injury, I hope that you're also kind of considering, from a 30,000-foot perspective, other populations with particularly motor disabilities. Okay, no questions. There must be questions.
I was going to ask Dr. Gator, from a QI perspective, in our rehabilitation center, do you think there's processes that we could pinpoint that might best help us to prevent development of that in our inpatients?
I would go a step further and say that rather than a QI, it needs to be a research project, and we are considering that. What we haven't done is we haven't looked through indirect calorimetry at what total daily energy expenditure is for these folks. And so when the dietitians come and they put in a diet, they are using the Harris-Benedict equation or some hopefully more recent equation to predict their energy needs. And I still think that we are overfeeding folks. We also need to know, as they transition into outpatient, it would be a good idea to know what their energy expenditure is out in the community. And ultimately, I think that we need to be paying much closer attention to those things, as well as their cardiometabolic risk profiles, as Dr. Nash reported out in his consortium guidelines, cardiometabolic risk for spinal cord injury. Other thoughts? We can just chew the fat for a few minutes, so to speak.
There's one in the chat, I see.
Oh, I'm missing it. Let's see if I can find it. How should we advise spinal cord injury patients how much less to eat? Half as much, 3/4? So again, I would encourage each of you to grab these manuscripts that are now available out of the yesterday's, it was just published, Topics in Spinal Cord Injury Rehabilitation. And we really do talk about determining energy expenditure and then assessing nutritional input. So we do have a registered dietitian and a PhD in nutrition in the department. She's on the call. Alicia, if you wanted to speak to that for a moment, that would be wonderful.
Hello, everyone. My name is Dr. Snage. I'm the registered dietitian. I just got my PhD in nutrition dietetics. We're starting the science study shortly. And basically, we're going to be looking at their energy requirements with the indirect calorimetry, and then see where they stand with their fat mass. And then we're going to just target like their diet, just making it a little bit healthier, one step at a time.
Dr. Farkas is also on the call. And so Gary, if you wanted to speak a little bit about the energy expenditure and modifying to total daily energy expenditure, that would be great.
Yeah, so second, to what Dr. Gator was saying, I think, there's been a lot of research lately discussing the importance of modifying the macronutrients. And I think it's really good to emphasize to patients the importance of having a higher percentage of protein and fat in their diets. There's been a lot of emerging research that talks about the ratio of those macronutrients to carbohydrates. So I think, emphasizing that to patients, and, it's interesting, excuse me, I was just thinking that, there's not a lot of work out there, recent work, that looks at the acute side of indirect calorimetry and then monitoring these participants through, acute care, subacute, and then into the chronic phase of their injury. And, we've seen in our work the amount of calories that they're consuming, and while it might not seem like a lot, when you measure it and you look at their lean body mass and fat-free mass, there's a really big difference in what they should be eating and what they are eating. So lots of opportunities for some inpatient research.
And Gary, would you speak briefly about satiety after spinal cord injury?
So satiety, meaning fullness, and how long that lasts. So that is a big question right now that we are going to be submitting a grant on, looking at satiety after spinal cord injury and what factors influence that. Is it behavioral, physiological? Is it anatomical based in terms of GI? We really don't know that answer. And that's an area that we're going to be looking into. And it's pretty interesting because when you look at those folks with SCI and their habits for consuming meals, they're smaller meals, maybe for breakfast, or they skip breakfast and then lunch, and then they have a huge dinner. And that dinner can be worth, what one of us would eat for the whole day. So, the question is, where are those calories, or not where they're coming from, but why are they eating so much at one meal versus, smaller meals throughout the day? And is it a physiological component? Is it an environment component? So we will be looking into that. So to comment, it's really hard too, because we don't really know that much about it.
Right. And because, extra body weight, if you are relying on your upper extremities to get around, to propel your wheelchair, et cetera, there may be some issues associated with that. Dr. Vivas. Dr. Vivas also has a publication in yesterday's special edition looking at upper extremity overuse after spinal cord injury. So if he's still here, perhaps he'll share a little bit of that with us. he may have taken off to get to my clinic just to cover for me. So, you just missed out on a wonderful opportunity, and I apologize. But our newest faculty member will be presenting on this at some point in the near future. And so thank you all very much for participating. If you do have additional questions, feel free to shoot those out to me. The topics in spinal cord injury rehabilitation special issue on neurogenic obesity just came out yesterday. Actually 11 of the 13 manuscripts came from authors in our department. So congratulations to all of you. And everybody else have a great day.